University is a beautiful campus with the isotope view in the background. And if you have some time during this visit, you definitely worth going up there to visit the isotope temple and got a good view of Chiang Mai city. Here we mainly work with another hospital. We have two major hospitals in Chiang Mai province, include Chiang Mai University and Nakhon Phanom Hospital. Mostly we do our case and do some collaboration between two hospitals as an aortic team. Especially in the complex aortic case, we perform many complex aortic cases during past 2 years. Overall, we start the complex aortic procedure around 2 years ago, and this is our approximate case number so far from CMU and Nakhon Phanom Hospital. First, we start with the modified endurance limb for internal iliac preservation instead of the use of standard IBD device because of the delivery or maybe some devices are not widely available in our country at that time. But for now, the IBD device are widely available in our country. So we select some cases that out of IFU for the IBD device to do the modified endurance limb. And I will show you the development of our endurance limb design. For the complex aortic case include paravisceral and thoracoabdominal. We also do some of the off-the-shelf device, include off-the-shelf around 10 cases and 2 cases for the CMD. And we done around 40 cases of the PMEG during past 2 years, include many complex cases that I will show you later. And for tomorrow, we will join with the CBT team and show about our practice in PMEG for thoracic arch. We done around 20 cases of the aortic arch with the PMEG design. Mostly we do in zone 2 for preserve the left subclavian. Until now, we have 2 cases that go beyond zone 2, include the 3 fenestration here and single fenestration combined with the bypass. And we also use some of the off-the-shelf device like caster that we done for 2 cases in recent month. This is the modified endurance limb technique that we initially start with the single fenestration as shown in the first picture. We do the small fenestration below the overlapping of the endurance marker, and then we proceed to develop more to do the outer branch design configuration like in the second figure. And you can see that if we do the outer branch design, we need to use the larger sheet to resheet this device because it's quite large and can't get back into the old delivery system. So we proceed to do the mini inner branch design to overcome this problem and got a good result for all of this design. And I also report our technique in the Journal of Endovascular Therapy in this year. And this is the last design that we just do. We do the fusion branch design by cutting some part of the strut of endurance limb and fix it with the PTFE graft. So we can do larger diameter of a small inner branch larger than this one because this one limited by the edge of the strut. So we do this one for make a larger hole for internal iliac artery and also get a good result in this design too. And we plan to report our outcome in near future. I also collect the outcome for this kind of cases, especially in narrow iliac, common iliac anatomy. Next, I will move to our full fenestration PMEG technique. Initially, we start with the full fenestration, simple full fenestration without diameter reducing time. In this kind of technique, we cannot deploy the proximal band stent because we can't rotate it easily. So it's quite hard to get the device or sheet through the proximal band stent. So this is a couple case that we do for this technique. And then when we meet more complex cases, we use the preloaded wire to facilitate the put the long sheet inside the fenestration. And then we invite Dr. Viran to teach us about the true and true technique combined with rolling encircling reducing time that he just reported in the maybe past year. So we use combine of this technique to overcome the angulated anatomy like this. We deploy the main device via the soft hydrophilic wire and use the proline encircle to create the gap between fenestration and aortic wall. So we can easily put the wire and select into the visceral band because the gap is quite wide. For this technique, we can deploy the proximal band stent because there's also the gap between the aorta and stent graft, and we can rotate it easily because the stent graft is quite small when we do the diameter reducing time. And we also use this technique to overcome some complex cases like this. This one has a type 1A endoleak after the AFX device, and the AFX device also dilated that caused a large endoleak to the patient. So we put the stent graft, PMEG stent graft here and do the small inner branch combined with preloaded wire and diameter reducing tie. Next, we try to avoid the upper extremity access by performing all transfemoral approach combined with using the steerable sheaths to improve the flexibility for visceral branch cannulation. We start with the straight anatomy that we can the procedure not that much complex. The device is quite well, and we do 2 cases and combine with the Nakhon Ping Hospital for 3 cases of this kind of procedure. All of the case has the straight anatomy, so we can do every branch from the femoral approach. Only one case that has the endoleak from the SMA stent dislodgement because of the during deployment the angle of SMA is quite sharp angle, so we will do the bridging stent for the SMA later. And unfortunately, due to our reimbursement limitation, we cannot use steerable sheaths in all of the cases. We have to select only in the patient that can afford the cost of the steerable sheath device. This is our interesting case that we adopt the visa technique that reported by Dr. Michel Biesa and use the endurance body to do the single fenestration combined with the endo anchor. You can see that in this kind of case we use in the juxtarenal aortic aneurysm and use helifix to fix around the neck to improve the sealing and also decrease neck progression over the time. The result is quite good, but I think that the endurance body has a limitation by its strut because the strut is quite narrow compared with the variant platform. And this is another interesting case that we just performed a few days ago. We used the inverted endurance body by inverted the one of the limb upward to fix the type 1A endoleak from previous endurance that has a dilate anatomy. You can see that the previous stent is here and become dilated, so we can't put any other device over the old bifurcation. So we do this kind of technique to put the endurance in the old endurance, and the final result is quite good without any endoleaks, but we have to follow the CT later. All of these are some techniques that we developed over past 2 years through many cases that we perform. And now I will move on our planning and sizing strategy for PMEG full fenestration. Mostly we use the HOROS program to measure and planning sizing. We imported the DICOM file and used the curve MPR mode to do the center line. We always start the center line measurement from 4 to 5 centimeters above celiac artery for the pararenal or juxtarenal case, and for the thoracoabdominal we go higher. And we measure the diameter for the proximal landing zone. And after that we measure the visceral distance by use the center to center of the branch. We mostly use the center line compare with the outer curve or lesser curve of the opening, the branch opening. In our practice, we use center to center of the branch, like shown in this figure. You can see that we mark the center of the celiac and use the celiac as a reference. But in some center like Korat Hospital, Dr. Vira used the other technique by measure the lower edge of the celiac down to the upper edge of other branch. So I think there are some difference between measurement technique, but the outcome is quite the same. And then after we measure the length for each branch by use the celiac as a reference branch, we will proceed to measure the clock orientation of the branch opening and start with the 12 o'clock position and then measure the angle to the branch opening and calculate for the arc length according to the size of stent graft at that part. But the difference between our center and Dr. Vira is Dr. Vira used the aortic diameter for calculate the arc length rather than use the stent graft size. Currently, there are still no standard guideline for planning and sizing in this kind of case. However, in our group, we always use the same approach, include both CMU, Nakhon Hospital, and some center in Bangkok, like Dr. Watanaki from Washira Hospital. We always discuss and share our experience between centers. Include CMU, PSU, and Korat Hospital, and compare our outcome. And then after we measurement and get the final draft for branch plotting in the paper, we will proceed to do the back turbo preparation for the PMEG. We start with secure the proximal part by seal tying here and deploy the stent graft. And then we mark the location of visceral branches according to our preoperative measurement and planning. We draw the fenestration here and we always do the transverse line here and measure for the length that we already planning. And then we rotate a bit to avoid the strap across the fenestration. After that, we secure the fenestration by suture the double loop snare. In some center, they use the tip of stick wire, and for the thoracic case, I always use the tip of backup wire or super cord to reinforce around the LSA fenestration because it's quite thick and easier to see in the fluoroscopy. But for fenestration, I think double loop snare is quite easier to resheath because it is quite thin. And in some cases, we need to do the inner branch like this. If the distance between our fenestration and aortic wall is more than 5 mm, we always do the inner branch. And in some cases, we also add the preloaded wire like this. This is the final picture of the inner branch, and we always insert the preloaded wire inside the inner branch. or some case that we think the anatomy is angulated and we can select into the fenestration easily, preloaded wire may help in this situation. And after that, we use the Dr. Virat technique by do the proline encircle reducing time by suture the proline between the gap of the fabric and strut to avoid fabric tear. And for reducing, some case we use just our hand to crimp the stent graft, but some case we use the valve crimper like in this picture to circumferential crimp the graft. We always crimp the graft and create some space between the aortic wall and the stent graft around 5 mm to 1 cm. But if we do the reduce too much, it's quite hard to put the long sheet inside the stent graft. This is the final picture of the stent graft after we do the diameter reducing tie along the stent graft, and then we resheath by use just simple silk tying and resheath the stent graft inside the old delivery system. Next, we proceed to the operative step. First, we do the angiogram compared to the orientation of the stent graft. We use the SMA as the reference mark because of the SMA is the most important branch compared to the renal and celiac artery. We use the SMA by do two view of angiogram, include the AP view of the SMA ostium and the lateral view of the SMA opening, and confirm that the SMA fenestration align with the angiogram. And then we deploy the stent graft until the SMA fenestration opening and deploy the proximal bed stent. And then we cannulation into each visceral branch by simple cat and wire. Mostly I use the Berthoud catheter to cannulation into each visceral branch. After we finish cannulation, we fully deploy and release the diameter reducing tie by use the aortic balloon to break the proline suture. Mostly we use the 5-0 proline to suture around the stent graft. And then we proceed to deploy the bridging stent and do the flattening in the aortic lumen. In our center, mostly we use the balloon expandable cover stent, mostly B graft, because it's widely available in Thailand. After we finish deploy bridging stent, we proceed to do the standard EVAR step. Some case we cut the proximal bed stent out and deploy the stent graft just below the renal fenestration. But in the case that we leave the lower part of the PMEG longer, we don't need to cut the proximal bed stent. But in some center, they believe that the hook of the endurance maybe cause the pinhole type 3 endoleak. We also met this problem, but it's gone after 1 month follow-up. So I think in the case like this, I didn't cut the proximal bed stent off because I think it helped to fix the endurance with the PMEG graft. And then we balloon for the overlap part and our profile finish. The final result is quite good in this case. For the conclusion about our practice, I think PMEG is customized technique, but require the complex and the good team. I think in near future we try to report some the standardized technique in Thailand, include many centers. I will get our result compared to other centers and try to make the standardized for measurement and also planning and include all of the technique from different center. Mostly, I think many center learn from Dr. Vira that he start to do the simplify of the PMEG procedure, and many center can follow by his step. It's quite good. And this is our case for today. The case was thoracoabdominal dissecting aneurysm 4.5 centimeter. During follow-up, this aneurysm grows from 2.5 to 4.5, and the patient has a symptomatic have abdominal pain. The patient factor has obesity and refused to do the open surgery. We advise to do the custom-made device repair, but due to the cost and reimbursement issue, the patient can't afford the CMD price, and also we can't wait that long for the symptomatic case like this. And this is the CTA scan for this case. You can see that the celiac and SMA come from the true lumen. And for the right renal, is combined both true and false lumen, mostly fulfilled by false lumen. Very small true lumen here down to right renal, and the left renal come from the true lumen. And in the below segment has some tortuosity, and down to iliac we can just place down to iliac bifurcation. As I mentioned before, we use the MOROS program to measure the planning for the case. And I always compare my plan with my team and also the Medtronic team, because there are some difference between the program. They use the endosite program, right? TMCO program, and the TMCO program always do auto center line, and some part of the aorta may be different. And especially in the angulated case, in MOROS program we can measure the lesser curve or greater curve length. We can just do the center line measurement. And I will use many view to compare and use the celiac center as the reference and measure down to each branch. Like this. I will move down here and measure the length between celiac down to each branch like this. I use the center to center distance. And this is the final draft that we will use in the operating theater. For the celiac SMA and left renal, we will do the simple fenestration, and the right renal artery, we will do the inner branch because of the small true lumen. We think that if we can cannulate into the right renal artery, we will sacrifice it and plug in the inner branch. So this is our case for today. And at this point, I would like to thanks to many of team, including CBT team, and also Dr. Vira, Dr. Vitwat, and many of my mentor that teach me a lot about the aortic surgery. I hope all of you enjoy our case today. Thank you. Because the marker that we draw will faint, and there's some ink. I don't like that. So it's just not put saline during on-table preparation.
When you deploy the graft, we usually use a step wire the aorta tends to straighten. So how does that affect your computation?
You mean during the procedure, right?
Yes, preoperatively, you sort of measure where the celiac ostia and the visual vessel osteas are. But that is in a normal aorta. When we deploy, we put in a stiff graft, the aorta tends to straighten. So will the measurements move? So how do you account for that?
There are some move in the real case, but I think if we measure, I train to put the branch higher than normal a bit, because if we deploy and the branch is higher, when we come from the arm, we can go to the branch. Some a little bit mismatch between fenestration and ostium is okay because we deploy the bridging stent. But if we plot the fenestration lower than the opening of the ostium, it's quite hard to select from the hole. But in the ambulated case, we still not have a good technique to measure because during deployment, some branch shift up, some branch go downward. So we can predict in that kind of case.
What is your usual access in the upper arm?
We use the cut down at the brachial artery
In the left?
in the right.
Right.
But how about the four vessel fenestration in the abdomen where you have 4 sheets? What is your upper access for that?
I use only one large sheet, 12 French or 14 French at the brachial and then insert only stick wire. I place only stick wire inside and put the daughter sheet to only deploy bridging stent. But I'm not put all the sheet inside the branch during the first time. So I just put the long sheet down and place the stick wire into each branch and then pop up the stent and put the daughter sheet followed by insert the stent in each branch. Start with the renal and SMA. Mostly we abandon the celiac stent, just do the fenestration and profile to the celiac. Only one case that has the type 3 endoleak from the celiac fenestration and we have to put the stent into the celiac artery.
So usually 3 covered stents
Yes.
for SMA and 2 renals.
Yes.
So you have 3 wires and 3 sheets at the same time? Or one sheet at a time?
Three wide and only one sheet. I think you have the case to share with us.
Bring my computer there. I have HDMI.
From the Philippines. Dr. Nelson Lee and I are from Chinese General Hospital. Chinese General Hospital is over 130 years old, actually. It started in 1891. Some people ask why is there a Chinese hospital in the Philippines? It's because in the 1890s, the Chinese people were not accepted in the local hospitals. So they had to build a hospital for themselves. Now Chinese General Hospital is a 600-bed hospital and soon to be 1,000 beds with a new wing. And the other team is from Philippine General Hospital. Dr. Leon Chocao and Dr. Aldous Tabasa are from the Philippine General Hospital, which is 100 and almost 120 years old. So both very old hospitals. Dr. Nelson Lee and I have been doing EVAR and TVAR for over 20 years, and I think Dr. Kao and Dr. Tabasa also almost 2 decades. And we're happy to represent the Philippines, the 2 busier teams in the Philippines. There are a couple of other busy teams, but we're 2 of the busier teams. For the Chinese General Hospital team background, I did my training all the way back in 1998, so you can do a quick calculation as to how old I am. But I was at the right place at the right time because Medtronic came out with Aneurysm. I don't know if any of you know the Aneurysm. That's the first ever EVAR stent. So I had training in that, and when I came back to the Philippines, I was one of the first to do EVAR in November of 2000. In 2012, we established our aortic endovascular unit with the help of internationally known person, Frank Criado. He came in from the US and helped us establish. He's a vascular surgeon. I'm an interventional cardiologist by training, and Dr. Nelson Lee is a TCVS thoracocardiovascular surgeon. In 2012 to 2016, actually, we also trained people to do EVAR. We were a training and certification center for excellence for Medtronic, and Medtronic brought a lot of local and international people to come to Chinese Ship for training. We started encountering very complex cases, and Dr. Criado told us that we could be using chimneys and snorkels and periscopes. And so we started doing a lot of chimneys actually, and now in our series we have over 100 chimneys and snorkels. But realistically, we know that probably fenestrated EVAR and TVAR is probably better, and that we should be having that in our armamentarium. So in 2023, I met a fellow of Dr. George Joseph, who is from India, who has done a lot of fenestrated EVAR. And in 2023, we started some communication with Dr. Joseph, but we never visited him and never really followed up on it. Until now, when Dr. Tabasa reached out to your center, and thanks to Dr. Tabasa, we are now here. Trying to learn fenestrated EVAR from all of you. We'll just share our first attempt at an aortic arch PMEG TVAR. We were able to achieve this with difficulty, but maybe you can help us make it easier for our next few cases. 79-year-old male, asymptomatic, heavy smoker with severe COPD. He had a chest x-ray just because he had a cough, and his mediastinum was noted to be widened, and the CT scan confirmed the presence of a thoracic aortic aneurysm measuring almost 8 cm. I used this graphic on the left because his aorta was very angulated and very large. And then he also had disease in the left common carotid and the left subclavian. We had not done any PMEG fenestrated before, so we wanted to keep it as simple as possible. So our plan was bilateral femoral access. We wanted to use a temporary pacemaker during deployment for more stability of the graft. We did the right axillary cut down to allow us body floss. And then we did 2-vessel aortic arch debranching with right common to left common carotid and left common to left subclavian artery bypass with ligation of the carotid and plug of the LSA. And the plan was to do a body floss from the femoral to the right axillary and do single fenestrated PMEG into the brachiocephalic with a limb graft self-expanding covered stent. into the aorta. You all know this. We look at this all the time. I've looked at all your videos. So it's nice that we can be here. All of your videos are fast forward, and a lot of the smaller details are not included. So we're here now to see all those details. But from what we could gather from all those videos, we did our own fenestration with single PMEG. Santana, who works with Dr. Joseph in India, is working with Medtronic, and Medtronic was nice enough to fly in SK to help us with this case. We marked our graft with the sterile marker, we cut through the scalpel, we double looped an 014 filter wire tip for the marker, and we pre-wired it with an 018 Roadrunner as per recommended by SK. And in the course of the next 2 days, we hope to find out from you what you use for pre-wiring and how that helps you in cannulation and all those things. So first, to achieve a body floss, we snared the wire that we inserted from the femoral into the axillary cut down. And then we advance our T-wire graft, and I don't know if you see on the screen, but SK noted that our wire is intertwined in the graft. So we tried to torque the graft. We brought it back down to the thoracic aorta and tried to rotate it and tried to untangle it, but it wasn't very clear whether we ended up intertwining it because we were torquing clockwise or counterclockwise. So we learned that we should really note how we are torquing the device. And we were torquing the device because we wanted the marker to be on the outer curve and not the inner curve as we entered. Be that as it may, I think there's still a little intertwining, but we were able to match our marker with the brachiocephalic, and we did partial deployment, and you can see the circular marker is here. We were able to cannulate the marker with a wire. We now inserted a stiff wire catheter through the marker, and later on the stiff wire. And you can see it's not really exactly at the ostium, so it ended up being slightly below. So we decided to put in a longer limb graft. We deployed 20-82 limb graft, and then we post-dilated it. And then we did the rest of the T-bar all the way down to the lower thoracic aorta. We post-dilated it like we usually do, and then we achieved this final result. So technically, I think it ended up being good. We see the D branches, the carotid and the subclavian. So technically it is successful, and we were happy with the angiographic success, but it took us, I don't know, Nelson, was it 5 or 6 hours? Yeah, so it was a bit of a struggle for us, so we want to learn from you how to make the 6 hours much, much shorter, because I think you guys probably do it in 2 hours. Unfortunately, this patient did not wake up. He had a large infarct in the right MCA territory, and he remained comatose for the next 3 days. And a repeat CT scan showed intraventricular hemorrhage and hydrocephalus, and the family was not aggressive, and this patient actually eventually passed away. So it's an unfortunate ending, technical success, but not clinical success. We're not exactly sure which part of the procedure led to this, but hoping to learn from this and have better outcomes in the future. So this is sort of our background and our cases to share for today.
For your cases, with arch? Do you do it a zone 0 arch? Do you do it same sitting or do you do it stage?
Do you mean in zone 0 combined with T1, right?
Yes. Do you do it as two separate procedures, the differentiating?
And the
then
same.
same sitting.
We start with the branching first, and we use the vessel that we already very cut out for the branching to cannulate. But it's like a little bit harder than use the brachial because the length for place the sheet is quite short. But we also met this kind of bad outcome like a stroke in the case that we do 3 fenestration, the patient also have a posterior circulation stroke. Even we put the filter in the internal carotid, both not artery. But I think the small plaque come to the vertebral artery and cause the posterior stroke. Even we protect it, but still occur. And Dr. Vira do many cases of zone 1 and zone 0 by put the filter in both internal carotid and vertebral artery. But I think for that kind of procedure in our setting is still limited because the reimburse of the filter and also the cooperating between team because we have less surgeon than Bora. He has a lot of team and he can put around 12 access for put the filter inside the carotid and vertebral and also for cannulation the branch and femoral access and I think he put some sheath in the femoral wing for him to control some blood pressure too. So I think it's quite a complicated procedure that I can follow this kind of case.
But was he able to reduce the stroke?
He do retrograde here and upward to place the filter.
Did he notice any reduction in the stroke rate? Or did it result in a good outcome for most of the patients?
Dr. Virat got a good outcome, but I still not get to that part. So in our case that we do the brachiocephalic fenestration, we totally clamp here and use the temporary perfusion by use the perfusion from the femoral.
You do the shunt first.
Yes, we do the bypass and put the shunt by cut down the femoral and do some small platform ground and place it up here. And then we use this to retrograde to put the bridging stems.
Do you have like criteria on when do you use that kind of protection? Say to see either from shaggy or not?
Oh, this is still the mystery because many cases we make the distal embolization for the stroke and also the case from maybe last month got a systemic embolization down to celiac artery and also renal artery. And the patient passed away due to the many organ failure. I think for the shaky aorta, it's quite hard to protect. We just try to avoid rotating the much.
Really?
Yes. In the case that we deal with shaky aorta, I discussed with the CVT team and we prefer to do bypass rather than put the graft and rotating for the fenestration. But in that case, we do on zone 2. I think zone 0 is still has many room for improvement for the stroke or spinal
Tim, in our case, do you think when you were pushing the device, should we be exerting a pulling action on the free wire? Because the first problem came when it was entangled in the nose cone, which we probably did not do a pulling on the. So there was a slack in the free wire, which made it tangle into the nose cone. So as we push, we should have.
But I think the entanglement occurred not because we did not pull, because we had to rotate.
When we were rotating.
Yeah, because the wire, the pre-wire does not come out centrally, it comes out of the sheath. And if you rotate, it will go around the stiff wire.
Do you have any technique to avoid that?
Mostly we tighten the below wire, and during we insert, we try to align it straight, and after we put to the arch, we tighten a little bit and rotate in the descending aorta and ensure not to enter with the nose cone.
We initially rotated in the arch.
No, we rotated below.
Below.
Because I think once you're in the arch, it's harder to rotate, especially with that aneurysm.
I think this one we do the same. Okay, so I think we have some free time to take some break and eat some snack before our anes team prepare our patient.
Do you do for this? Do you still do spinal drain?
Mostly if we cover longer than 5 centimeters, we do the pre-operative on the head. Because our anes team don't do emergency drain for the patient.
Some centers who have probably on-call anesthesiologist who does when there's some problem with your emergency tab. But we use that, and when something happens, when we're observing a neurologic cases, we do not call any anesthesiologist to come and put in the recap. They came the following day, so we completed the port problem.
We stated we offer before, maybe on day by day, we did it on Sunday. Well, can you come? Emergency is cannot be an option. Let me
I think the use the photo and it's burning more than
Talaga? Lahat lang yun. Kaya ito ba? So,
Bakit siya na bang
Yes, sir. Ito na yung nakapuli na retiring yung 2 years. Yung
63 na? So, hinatay nila lang. Sino susunod sa kanya?
Dr. Tommy at sa CMU, baka niya si Dr. Lakman.
So, ano naman siya? Pro.
Oo, yes. Basta po.
Tapos kumatakbo na kayo ngayon. Basta po.
dito lang, no problem.
Then I'm running to the
Yeah. See? It's not just us asking for it. Everybody's asking for it. They always give us the excuse. It's not in the ISU, so they cannot do anything. So you have to publish a paper that it works, so it will be within ISU.
how many images of the 40 to 42 CD the core leader, the white one.
Cortex.
Cortex.
Yeah. PTSD suture.
No, it's okay to use it.
But when we do small penetration, the CV is quite big
Yeah,
and also it's expensive.
Yeah, very expensive.
and not
It's just
available.
that it's not available. The nice thing is it doesn't leak.
The sizing is 1:1.
Yes.
Not the whole smaller, smaller everything. So it will more fun.
For the PTSD graph, we have different sizes. Parang 6 and 8 lang.
What is the one that based on PTSD?
But we use six.
Six,
But what is the different branches like that? 4 millimeter.
So I just do six and do the smallest graph that we have is
Kaya iba ng POBA pa na. Ang daming gamit ng POBA.
Usually.
Hindi ito pang PGH kasi close ito mga ganito.
alright.
Kasi sa PGH lahat binibilang. Yung lahat ng gamit. Dito ang dami mo ito gagamitin.
ก่อนมาจะ
Mas near na ano.
because many of young doctors want to
vascular surgeon.
Work-life balance. But for vascular, never balance.
Apply ako sa PG.
But I try to call my team because is that the same?
Okay. More or less the same.
We're having a hard time. It's hard. Learning is my favorite to cultivate. We don't have perfect all of our have things
Kaya tuloy ang papansin. Para mas bigay, no? Kasi parang ganito eh. Kasi yung gamit sa yung cover glass lang ang problema talaga. Compare to the former.
Tama, pahiram naman.
Kasi ito lang ang nahirapan sa individual.
Sabi ko ba karami volume? We're doing running.
Yes.
Look, meron ko sa pero yung corn ayan yung na-paper. Kasi last time, ano kami, yun yung ginamit namin.
Meron. Yan ang yard na picture lang.
Hindi, calibrated.
Calibrated lang.
Oo, wala.
Regular picture lang.
Ba't ka may biglang meron doon?
Ah,
Regular item ba ito?
Hindi. Ay,
Baka yung mga nahanap ko.
Yan ang RJ.
Ito regular sheet. So dito lang yung babo.
Floor mounted na.
Ang ceiling mounted kasi nila ay ceiling is modified to
Hanggang 9 times lang yun.
pero hanggang
pan may araw, minimum.
This is an inner front. Yes. How much cm do you allow? 1 cm?
1.5.
1.5.
Actually, I want to do.
Kasi tatahip na tayo nila. Unahin nila yung
Papasok naman siya. Eventually, it will go inside.
Do you tuck in the inner right? Do you tuck it in the right?
Yes.
tatahip siya sa loob. Kung hindi siya sa
Dali lang yung parts. Hindi po na-analyze na lang natin. Yung nangyarap yung pag-work.
Dami, nakasalamin na ako.
wala ko din talaga. Tala ko naman pa. Kami nakalupat na oras na yun.
Nakapit natin sa saan sa
Singapore. So, success dito, meron siya may RD.
sa left
Yes, sir.
left ang ginagawa.
Baka ganun kasi ang requirement sa RD. Kailangan mo talaga ng maraming wire.
Hindi niya yun kaya, no?
Chong.
Siya yung pumunta sa amin, so nag-IDR kami.
Yan.
Mas mahal pa yung sasakyan niya. Kaya sila, hindi sila bumibili ng mura. Bibili ka ng di ba, permit to own na 2 million, tapos bibili ka ng 1 million na sasakyan.
Parehas lang yun.
Useless, di ba?
Pero transferable yata yung permit to yun.
It's 10 years. Parang ganun, may span of time. Pwede ka every year bumili. Ang tabo yung ano na.
Very nice.
Ano ba yung brand?
RTC ko mas bago na yung ito yung una.
I think heart center siya.
Yeah, only heart center, I think. But it's hard to do cases there. They move very slowly.
Tapos control.
Pero, sila dapat
So hybrid. That's a good question. I think hybrid because most of them let me ask.
kasi usually a hybrid belongs to the surgeon.
แล้วก็ทำหรือทำการจัดจ้างเป็นตัวเสริมสวย
คนนี้ก็
ใช่ เรื่องนี้จะพยายาม
Bisa, sampai sini. Aku pun mencuri. Kalau lumabas mo yun, kasi kata kanina ko, parang may yun na lang. Di ba? One more point five. Patay dito, para yung sales story na siya. So center always have the SMA. Versus that really can stay for concealed from malaria. With the molding balloon can crack the
It becomes like a DUI.
Yes, it's
Functions like an DUI.
because that case, if we can place the stent at different part, we have to do KUI and do
That's now a lot. You don't have to do
yes. From there are the report from Dr. P.S. that he do the reducing time at the posterior, like
I've seen that. Just a suture in the back. Right?
yes, but
Kasi tinusok ka na sa labas ng
Gagawa sa atin yung Santana, yung itutusok pa dun sa yung sinet kasi namin. May pre-wire siya na. Maganda yung actually, no? Kung mas nila ito.
American.
Taking out of the catheter from above, close the catheter. Just to get through the hole. But then after you get through the hole, you have to wire and send a set
It may cause some bleeding here.
covering and covering. Hirap tayo sa pagiging. The mold sa kaya. He's winding up here. Yung mali siguro na kami sa high center kasi require na malaw. Blood count yun.
aneurysm. He has a long and really active smoker, like 50 packs a year, and a serious COPD. Like you see on the chest X-ray, the lung has many emphysematous and like a giant bulle on the both of the chest beam. From his CT, yes. From his CT, we find that very large of the giant bulle here, and we discussed that this is a Dr. Nopon cases, and we think if the patient need to do the total arch, it's maybe not survive from the cardiopulmonary bypass. So this case we decide to do total endovascular. Here is you see that the aneurysm is on the arch and no good landing zone here. So the landing zone, even the 1.5 centimeter, is covered in the artery, and so we need to landing on the zone 0. And one thing that both of the access sites is also have an aneurysm and a very stenosis of the both legs. So the planning in the problem of the patient is a sacral aneurysm of the aortic arch, and the patient also has the groin arch, and he also has the PAU on the descending aorta size is around 1.2 centimeters, and fusiform aneurysm of the bilateral hormone artery for 1.5, 1.6 and 1.9 in the left. So the lung is also giant bulle and very serious of the COPD. And he also have one vessel disease on the LAD. So but the echo is good, no valvular heart disease. So we decide to do the total endovascular, like a proximal landing zone on the zone 0. And the planning of us is like do for interposition graft on the femoral artery to be get rid of the aneurysm on the femoral aneurysms, and we done the shunt from the left femoral artery to be supplied to the bypass valve on the aortic arch branch. And why we put the stent to occlude all the aortic branch, we also do the fenestrations on the intermediate artery. And after that, the aortic arch branch for the carotid, both carotid and subclavian, also supplied by the shunt from the femoral artery. So during we deploy the stents, brain is supplied by the femoral shunts. After that, we do the fenestrations. And this is the planning of the Dr. Nopon. And they have some accident while we do the endovascular, like this one. Oh, sorry. And this one is like an angiography. And the next, so, okay. And at that time is we try to do like some technique on the intermediate puncture for the fenestrations, and they have sorry. Sorry for why. Yeah, we find that is the ascending aorta has the dissections by our Y here, and the echo also show have a flap and like a hematoma on the ascending aorta here. So it's like a acute dissection surgery. We do the cases, and we try to continue the surgery because Dr. Nopon, he think that the puncture site by the Y, like a proximal anti-tear, is just by the Y. If we deploy the stent is cover the proximal anti-tear is maybe can get rid of the proximal anti-tear and maybe cover the dissections and continue our plan. Okay, so we continue to deploy the stents with the quickly of the deploy. So the stent can finally the stent can cover the proximal tear of the wire and the ascending area. And when we follow up for the CT after that, the aortic was remodeling, and they has no the dissection part in the ascending as well. And after that, we also done the fenestrations on the proximal and do the stent. This one, fenestrations, and after that we put the peripheral stent there. And of course, because we already done the bypass for the carotid subclavian, so just fenestration on the illuminate, like illuminate, and can go through the all of the aortic arch branch. Like this one is the final angiogram. So, and the CT after that is quite good. It has no, this is a bypass and no aortic dissection left on the ascending wall here. And the aneurysm also covered by the outer stents. And the patient has still survived. So let's get back here. So for our today cases is the 74 years old females, and she also has hypertension and dyslipidemia. For the last 4 years, she has a diagnosis for acute type A dissections, and she also underwent ascending and the partial arch replacement on the zone 1 with the diaphragm graft size 76, and then the illuminate translocations on the proximal leg here. So after the follow-up for the CT in each year, the size of the residual dissection is expanding. From the 2024 is the arch size is 44.2. And the early of the last year is 4.5, and the late of the CT is a very quick growth of the aneurysms from to the 5 centimeter of the aortic arch. But the descending is also the same one. So we think that due to the quick growth of the aortic arch size, so we plan to do the endovascular therapy for these patients. So this is a CT of the patient. So as you see, they also have a residual of the dissections and become to the dissecting aneurysm on the arch parts. So by previous surgery, we also have one translocation for illuminate. So the second operation for the tumor, we can landing on the like a zone 0 on the graph next to the translocations once. And if it's usual, we also used to do the carotid subclavian bypasses. But for these cases, maybe the planning is maybe different, because when to do the usual bypass, they also have like a graph like here, maybe like a necklace in the neck here, and this patient is also old and thin and very like how do you say the old women. The skin is not intact, so we plan to do the PMEG on the left subclavian and do just only left subclavian to the carotid bypass. So all of the arch band is maybe managed by the like a reverse flow by the PMEG on the left subclavian and through the bypass to the carotid. So let's see the CT of today's patients. ขอสวิตช์จอหน่อยครับ So before we switch, and you see the they have the two lumen to the left subclavian there, but another part is is a false lumen. So let's do this. Let's do the CT again. ขอเปลี่ยนจอหน่อยครับผม So due to the, we also have the experience for the cases that we do like reverse bypass to the carotid, like we have one cases done by the stem tester that they have the left subclavian branch. So we also do like this to the left subclavian carotid bypass and then the branch left subclavian branch to the left subclavian, and so it's like a reverse flow to the carotid. This is a CT, the latest CT of the patients. So we also see that the arch is like 5 centimeters, and the true lumen is from the graph from the first, and the true lumen is so the false lumen is also start from the anastomosis suture. There is maybe some like dense distal anastomosis new entity like that. So the stent must be over the anastomosis part that is over the vein also, and go up a bit. Sorry, to see the subclavians. I think we can also do the PMEG on the left subclavian, because the left subclavian is come from the true lumen here, and there has no connection between the subclavian part and aortic arch part to the false lumen. So if we put the PMEG like a band to the subclavian, is maybe cover to all the true lumens and maybe have the false lumen emerging in the futures. So I think this case is maybe done like just only carotid left subclavian bypass and then the PMEG on the left subclavians. So let's go to our planning here. Okay, thank you. Okay, so this is our plan here. For the proximal side is on this one is next to the bypass. The translocations on the graph. The graph side is in the operations is 26, but now is when we measure the size is usually up onto the 2 millimeter by the CT. So the size is around 27 to the 29 on the proximal size. And of course, this one is the aortic dissection. So we need to be landing far as we can. So the landing with the distal landing zone is around here. And for the measurements for the distal landing zones, like two lumen here, the widest part of two lumen around here is around 26. And for our distal landing zone here, the two lumen is around 21. So the true lumen on the distal landing zones everywhere is around 18 to 22 like this. So the size of the stent is 24. The oversize is not more than 10% is maybe the better for this one. So for the proximal valve is around 30 to 26, and the second one is 24 or 2 cent. And of course, this one is vertebral artery. The size is around, patent is around 4 millimeters. So yes, subclavian also need to be bypassed like in the guideline. We also measure for the left subclavian here. At the proximal, the left subclavians, like an origin, is around 18. But in the distal part of the left subclavian is around 8.8 6. So the stent for the peripheral, when we use the 10 or 9, it will be proper for these cases. So from the, okay, here is this one is the proximal landing zone here, and we need to do the fenestration around here. The length from the proximal side of the stent to the mid or part of the left subclavian here is around 7.2 centimeters. So in the center of the fenestration is from proximal stent is 7.2 centimeters. So we put the fenestration here. The side is maybe 8, right? Yes, for the center. And we also use the pilot line technique to be insert the stents. So in the scheming of our plan is maybe like this. Yeah. So we do the carotid subclavian bypass and then the PMEG for the peripheral stent here to the left subclavians. And the stents also cover the vein that come from here and also cover the proximal of the origin of the carotid artery. And the flow is combined here to be for the left subclavian and carotid artery. Yes, maybe finish off my presentation and today planning of our cases. Does anyone have questions?
The problem is that for the aortic surgeon, maybe you have to keep focusing on the LV wire, not push it. It must be one guy that keep holding that wire, not push in, not push out, keep it there. This is really important part of TAVI. So, but it is possible that we can pass the wire into the LV and then you can use the nose cone going down into the LV also. Yes.
We have problems when we have patients like this who have previous dental surgery.
Okay, dental is a big problem because mechanical valve and surgical valve. If you put the wire down there, the valve is open.
Have you thought of cutting the nose cone? Because the nose cone of the enteral is like
I totally agree with you. The big problem in this kind of operation is that the mechanical valve, because we should not pass the wire into the LV, and if the nose cone is pinched into the leaflet, it maybe cause some fracture or something. That is a big problem. So, in my idea, is it possible to do the dental in the patient with dissection, 60 years old, change the bioprosthesis to be better? But sometimes the patient may be younger than that, and you have to use a mechanical valve. I agree with that.
And one more thing that I bring is more higher than usual. So, if in my usual practice, in my idea, if we do just carotid bypass, and we also landing here, but for the PMEG, one for the left subclavians, the proximal nose cone of the stent is have the problem when we push on the glove, because the proximal part is the, how do you say, is the glove, is not the aorta, is the flexible one, and when we push the nose cone, it's mostly the glove is like clinking easier. And
so is the reason why we have to pass the wire into the LT. So it's big issue.
Yes.
And one more thing that I think is that how to manage the left common carotid stump. That is one thing we have to focus. Because actually, I think this is a dead also, but the re-entry occur at the left common carotid artery, because there is the dissection there. It must be some re-entry there. This is a big problem. So, in my idea, cut it.
Yes.
Close it with a clip or whatever. Leave it. Don't leave it there. Don't do the plug. Don't do the coil. It's going to be.
Yes, I have to like it.
Yeah, have to like it.
A filter, yes, on the carotid artery, but I think just bypass like this one is maybe did not use it. Just monitoring the noise enough.
In my idea, it depends on the disease that you're gonna deal with. Either there is like aneurysm with a lot of clot in the ear. That I think whatever we want to do, we have to try as wet as possible. Put all the filter into the brain or whatever. But if the lesion is like this, the aorta is green and this is dissection, there is no clot in the lumen, I think it is okay to use successfully the nerves. And I don't know, and our operation when we're dealing with the bypass is quite fast, so we don't need to worry about that much. Tomorrow we're gonna do the TAVI via the carotid artery, and we have to operate the carotid artery like 30 minutes. That is a big deal. So that in that case we have to monitor the distal pressure and then look at the nerves. If the distal pressure is dropped, we're gonna do the bypass from the femoral, not the bypass, so they put sheet, the big sheet there, and they do the shunt and puncture another a sheet going up to the brain. So if it's something like that, this is like a protective measure if you have to clamp the carotid artery quite long. But it is
carotid access.
Yeah, carotid access to the TAVI.
Left carotid.
Left, sure. Left.
Because the one we presented yesterday, we had a PMEG, the one that presented by Dr. D. Though, as you said, these patients had thrombus formation in the arch.
Yes.
We were
Penetration, we use the snare loop because it's quite thin. But if we put this one for penetration, it's quite hard to reach it.
yeah.
Hindi, nag-high lang ata.
Pero formal po.
Formal chronic and hospital, I think.
Hindi ano mo, tapos puputulin mo. Deploy tapos i-shoot. Yung distal naman ang puputulin. Ginagawa naman ganyan. Kasi mahaba yun. Ang tanong, pag natangkad, hindi ka maabot kung femoral yung access na siya. Narapasok na ito. Kasi ang puputulin mo yung distal yan. Hindi papasok mo sa mga. Ganun na ginawa niya. Pwede ko 3-5 na lang. Hindi mo sa mga mo. Hindi mo sigawas, hindi mo 3-5 lang. Hindi ba yung napos lang? Nag-unravel? Hindi, ang drive solid. Yung solid siya, no? Ang filament ang mag-unravel kasi naka-coil siya. So kung visibility, mas visible mo yung loop sa thoracic kesa dito kasi hindi naman water. Have you used JJ 435 light wire as a smart?
Ang kanila, nilanggal nila yung yung fabric.
You can see that to make this work, the wire should go anterior along the delivery system and also inside the ground too.
Yeah, rotate hands.
Maganda yung creeper. Maganda yung pagkain. Ganyan siguro pag-creeper.
Sa factory.
Kaya siguro niya i-trip para matay yung dalawa.
หัวไป
อย่าโดนของพี่แล้วกัน
โอเค
200,000นะเองพี่จะช็อปนะ200,000
ของนักแข่งพี่เจมไม่ร่วงหรอก
พี่ว่าเลยล่ะเดี๋ยวเต๋วในติ๊กบ้านแล้ว
Siya itong flash naman niya.
Hindi pwedeng malayo kasi hindi din siya nakagaling na sa harap. Kailangan sakto-sakto. Ganyan naman ang dapat na
เราต้องหนีบเราต้องแบบอายมันดี
yung muna tayo.
แล้วเราต้องมองเห็น
ยิ่งอยู่ก็เลยเป็นตัวเด็กดูผิดไหมผิดไหม
Okay lang. Yeah, I'll put it in there, right? Or on the table.
Once pumasok, madali na lang. Kahit na ito, madali.
Paano natin siya nakakagos ng kapag pinagos?
Tapos sa siguro sa tao. Tapos sa siguro sa tao. Hindi sila. Bakit pa sila?
Tingnan yung dissection.
Dissection siya.
Yung dissection.
Part medicine. Kailangan mo tatapos. Necessary.
Just kidding, just kidding.
Tapos sila.
Pero mas mahirap ng nag-paper.
ต้องมีคุณมาช่วยกดนะ
Thank
เป็นการเสือเจียนนะเจียน
เชื่อผมไหมว่ามัน
Thank you.